Gastrointestinal disorders. First, gastrointestinal tract is about 5 to 6 meter long and consists of upper and that oral cavity, esophagus and stomach, and lower gastrointestinal tract, small and large intestine. First is condition tracheoesophageal fistula and esophageal atresia. Esophagus do not develop properly. Esophageal atresia, congenital failure to the esophagus to develop a continuous passage from pharynx to stomach. Tracheoesophageal fistula (TEF), abnormal connection between esophagus and trachea. In that pathophysiology, during fourth week embryonic development, cells of endoderm form primitive gut. Defective separations of gut and incomplete fusion of tracheal fold or abnormal growth of cells cause this defect. Approximately 50% of neonates with TEF also have other abnormalities that are represented by acronym VACTERL: V vertebral column defect, A for anorectal malformation, C for cardiac defect, TE for tracheoesophageal fistula, R for renal anomalies, L for limb anomalies. Risk factor: polyhydramnios, in that amniotic fluid more than 2000 ml, premature infant born before 37 weeks, low birth weight babies below 2500 grams, single umbilical artery. In the tracheoesophageal fistula types, in the type A, 5 to 8% chances, it is an esophageal atresia without fistula, discontinuity of esophagus, but there is no fistulous connection between esophagus and trachea. Type B, rare, upper part of esophagus connect to trachea. That type C, most common type, 80 to 25% upper part of esophagus is blind and lower part connect to the trachea. Next, D, 1% lower and upper part of esophagus connected to trachea. Type E, H type, no esophageal atresia but esophagus and trachea are attached in H shape. In that H shape, D type, C type, A, B type and A type. Clinical manifestation: 3 CS, coughing, choking, sinuses during first feed, frothy saliva in mouth along excessive salivation or drooling, increased respiratory distress during and after feeding, abdominal distension, then regurgitation and vomiting. Diagnosis: X-ray shows air bubbles in the stomach. Large size orogastric tube stops after distance of 7 to 10 cm. Insertions of unable to reach stomach. Management: as soon as tracheoesophageal fistula diagnosis, stop to attempt to feed. Monitor for dehydration and administer IV fluid as per need. Turn the patient frequently to prevent the atelectasis and pneumonia. Give supine semi-upright position, 30-degree elevations to prevent aspiration. Suction upper esophageal pouch and pharynx at the interval of 5 minutes. Not given anything by mouth, NPO, and only IV fluids can be administered. Surgical management: there are two types of surgery are most commonly used. If distance between lower and upper part of esophagus less than 2.5 centimeters, do ligation of fistula and anastomosis of both end of esophagus. If distance more than 2.5 centimeter and condition of if infant is poor, perform staging surgery into two stages. First stage, esophageal fistula is ligated and gastrostomy is performed to provide feeding. Gastrostomy feeding: surgical creation of a gastric fistula through abdominal wall, used mainly for introducing food into stomach. Indications for gastrostomy: to decompress the stomach and prevent aspiration. Esophageal atresia requiring a temporary gastrostomy feeding. Infants requiring prolonged artificial feeding. Observation during gastrostomy feeding. Check residual amount of before feeding. If residual amount is more than 100 ml, then not give to the next feeding, because large residual volume indicates delayed gastric emptying, which may cause aspiration. Keep the tube clamp and funnel should be 20 to 25 centimeter above the level of stomach. Check pH of gastric aspirate. It should be 4 or less. Feed should be lukewarm and the end of feeding instill the small amount of water and clamp it. Second stage, perform esophageal reconstruction with a segment of colon at the age of 80 months. After this repair, gastrostomy is closed and starts to oral feeding. Then pyloric stenosis. Congenital hypertrophied pyloric stenosis, narrowing and obstructions of lower portion of stomach pylorus due to hypertrophy of pyloric circular muscle stomach. The circular musculature of pylorus is thickened and increased in size of the shape of olive. It is the most common neonatal intra-abdominal condition requires surgery. It may be congenital or acquired. Five times more common in boys than girls. Symptoms start seen after 3 weeks of birth. So weight of infant increases 1 to 3 weeks and after that starts vomiting. Clinical manifestation. Symptoms usually starts to appear between 2 to 4 weeks of age. Vomiting progresses from mild regurgitations to forceful and projectile vomiting. Then vomiting contains milk, mucus and blood but not contain bile. Olive-shaped firm mass in epigastrium or right hypochondrium. Peristaltic waves are seen during or after feeding in epigastric region from left to right. Then metabolic alkalosis. Child feels hungry, constipation, greenish stool due to starvation. Diagnosis. A barium meal X-ray study reveals delayed emptying of gastric contents. Surgical management. Pyloromyotomy. Friedent Ramstead procedure. Incision and suture in the pylorus or pyloric sphincter through laparoscopy. Surgery performed within 24 hours of diagnosis. Then gastroesophageal reflux disease, GERD or cardiochalcia. Backflow of gastric content into esophagus due to relaxation or incomponence of the muscles of the lower esophageal or cardiac sphincter of the stomach. Causes: transient relaxation of lower esophageal sphincter, delayed modulation of neuromuscular control of esophagus, raised intra-abdominal pressure, hiatal hernia with incompetent sphincter. Then sinus symptoms. Common symptoms include heartburn, indigestion, and non-cardiac chest pain, recurrent regurgitations, vomiting, and hematemesis. LRI, lower respiratory tract infection due to aspiration, poor weight gain, and anemia due to blood loss. Complications: esophagitis, esophageal stricture, aspiration pneumonia due to aspiration of gastric contents. Treatment: keep the child in semi-upright position 25 degrees to 45 degrees after feeding and keep supine during sleeping. Elevating the bed to 6 to 8 inch, 15 to 20 centimeter on blocks. To hold the baby against the chest and pat it on back to induce belching, called as burping. Give small and frequent feeding. Give thickened infant formula 1 tablespoon 50 ml or 3 tablespoons rice or cereals are added in 180 ml milk. Avoid feeding with fatty as food, chocolate, fruit juice, citrus fruit, and spicy food. Advise to avoid vigorous play after feeding and avoid feeding just before bedtime. Then management. In that surgical management, fundoplication, Nissen's operation. It is used to treat gastroesophageal reflux and or hiatal hernia by re-establishing gastroesophageal angle and creating a barrier to intrathoracic gastric displacement. In this surgery, fundus of stomach wrapped around the lower esophageal sphincter, a 360-degree wrap to prevent reflux episodes. Thrush, oral moniliasis, candidiasis, fungal candida albicans, infection of mucosa of oral cavity and tongue. Clinical manifestations: white plaque, milky curd-like lesions on tongue, lip, and buccal mucous membrane, which left bright red bleeding base when removed. Management: use antifungal drugs or 1% aqueous gentian violet. Next, congenital agangliotic megacolon or megacolon or Hirschsprung disease. Congenitally absence of autonomic parasympathetic ganglionic nerve cell in the submucosal mesenteric plexus and myenteric orbax plexus of distal part of colon and rectum rectosphygmoid area, which is result in extreme dilation of colon, more common in male than female, 4:1. This disorder mainly found in with Down syndrome. 64% cases diagnosed of till third month of life. Clinical manifestation: infant cardinal sign is unable to pass meconium within 36 to 48 hours of birth. Abdominal distension with 1 to 2 days after birth. Refuse to suck. Bile, stain or fecal vomiting. In the children, vomiting and abdominal distension, foul smelling stool, and may be in a pellet or ribbon-like form, failure to gain weight and delayed growth, malnourished and anemia and constipation. In that complication, colonic mechanical obstruction due to inadequate motility in an intestinal segment, hypovolemic shock, and enterocolitis, a serious complication. Diagnosis: plain abdominal X-ray reveals severe gaseous distension of bowel. Barium contrast enema to demarcate normal to abnormal part of colon. Rectal biopsy shows absence of ganglionic nerve cells. It is a gold standard for definitive diagnosis of megacolon. Medical management. Medical management: give low residual diet like low fiber, high calorie and high protein diet. Daily rectal irrigation with normal saline to promote elimination and avoid obstruction. Surgical management: pre-operative management, maintain NPO, measure abdominal girth, never take rectal temperature, observe respiratory distress. Aim of surgery is to remove a ganglionic malfunctioning and dilated part of bowel followed by anastomosis of remaining portion. It performs in two steps. Initial surgery, temporary colostomy in ganglionic bowel to remove obstructions and allow dilated bowel return to the normal size. Then definitive or reconstructive surgery. It involves it involves complete surgical. Definitive reconstructive surgery. It involves complete surgical correction in which normal bowel attached to anal opening by pull-through procedure at the age of 10 to 12 months, 15 months or at the weight of 7 to 9 kg. There are three types of surgery. Domhal's procedure, retrolateral transnal pull-through. A ganglionic colon proximal to rectum is rejected and side-by-side attachment of normal ganglionic colon to posterior wall of rectum performed. Swanson procedure, rectosegmentectomy, a ganglionic segment of bowel cut and removed and remaining normal bowel attached to anal sphincter. Swas operation, endorectal pull-through, mucosa of rectum is removed and ganglionic colon pulled through the muscle sleeve of rectum and anastomosis with anus. The optimum age of reconstructive surgery is 6 to 8 months. After temporary colostomy, initial surgery. Postoperative nursing management, avoid taking rectal temperature, observe redness, swelling, and drainage at surgical site. Observe stoma. Stoma should be pink and moist, and apply zinc oxide ointment on skin around stoma. Keep the patient in pure till normal return to bowel sound. Normally it healed within 48 to 72 hours of surgery or flatus pass. After returning normal bowel sound, provide non-eating bland diet.